we are going to discuss another disease which is tuberculosis, that is tuberculosis of the intestine. Now, tuberculosis of small intestine may take two forms, primary or secondary. Primary intestinal tuberculosis caused by bovine type of Mycobacterium tuberculosis. However, the incidence of this disease has decreased due to pasteurization of milk. There is involvement of intestinal lymphoid tissue which is inflamed and swollen. Secondary intestinal tuberculosis is mainly ulcerative type. It is seen in patients with active pulmonary tuberculosis. Ulcers are usually seen in any part of the small intestine, but they are more commonly seen in terminal ileum. I repeat, ulcers are seen in any part of small intestine, but are more commonly present in terminal ileum. Disease starts in the lymphoid follicles and Peyer's patches, which enlarge and undergo caseation necrosis and then ulceration. Now, it's a very important viva question that ulcers of tuberculosis in intestine, they are transverse to the long axis of the intestine. Ulcers are transverse to the long axis of intestine, which are seen in tuberculosis. Complications, there can be peritonitis with ascites, adhesions and fistula formation, stenosis and intestinal obstruction. There is intestinal ulceration. Fibrosis is the result of healing, and that leads to intestinal obstruction. Diagnosis, blood examination with ESR, Monto test, Zn staining, AFP culture, X-ray chest and abdomen, microdot test, PCR, fine needle aspiration cytology, and biopsy. Then we will briefly discuss food poisoning. Now, food poisoning is the term used to the acute infections of intestine other than cholera, dysentery. It is characterized by abdominal pain, fever, and toxemia. Abdominal pain, fever, and toxemia. Some strains of E. coli, Streptococcus, Clostridium, they are responsible for food poisoning. Large group of viruses, including rotaviruses, adenovirus can cause food poisoning in children. Now we come to the most important topic is inflammatory bowel disease. Inflammatory bowel disease is a chronic relapsing disorder resulting from complex interactions between intestinal microbiota and host immunity in genetically predisposed individuals, which results in abnormal mucosal immune response. So it is a chronic relapsing disorder which results from the interaction between the intestinal microbiota and the host immunity in genetically predisposed individuals, which results in abnormal mucosal immune activation. So there is an interaction between the microorganisms which are present in the intestine and the host immunity in genetically susceptible individuals, which results in the abnormal mucosal immune activation. Now, two very important diseases. Crohn's disease, granulomatous disease affecting any portion of the gut. Very important. Granulomatous disease affecting any portion of the gut. Ulcerative colitis, colonic disease, and no granulomas are present. Okay. Now this is the simplest diagram showing the morphology of the Crohn's disease. Number one, it is a granulomatous disease. The inflammation is involving all the coats of the bowel wall, and there are deep fissured ulcers. Ulcerative colitis, as I previously told you, no granulomas. Mucosal inflammation, and the ulcers are superficial, unlike that of deep fissured ulcers which are seen in Crohn's disease. Now I'll discuss these diseases. Crohn's disease, discovered by Crohn in 1932. Chronic disease, etiology is unknown, involve any part of the GIT as I already mentioned, but mainly terminal ileum. So it is also known as regional ileitis or enteritis. The other name is, examiners are very fond of asking the different names of a disease. Regional ileitis or regional enteritis sometimes can involve mouth, colon, and anus. Now regarding epidemiology, there are following features present at any age, young childhood to advanced age. Now there are two peaks. The major peak is between 20 to 30 years, and then there is a minor peak which is seen in 60 to 70 years of age. Females more commonly involved, whites they are more commonly involved than non-whites. White Jews are more commonly affected than the non-Jews. Now there are many factors which are responsible for this disease. First is the hygiene hypothesis, which suggests that the increased incidence is related to storage condition of food are improved. So hygiene hypothesis suggests that the storage conditions of the food they are improved, contamination of the food is decreased, and changes in the composition of gut microbiome that result in the underdevelopment of regulatory processes which limit mucosal immune responses. So storage conditions are improved, food contamination is decreased, and there is changes in the composition of the gut flora which result in the underdevelopment of regulatory processes which limit the mucosal immune response. This allows mucosa associated microbes to trigger persistent and chronic inflammation in the susceptible hosts. There is underdevelopment of the regulatory immune response. There is going to be persistent chronic inflammation in the susceptible host. There is another explanation for increased incidence of IBD, that is inflammatory bowel disease, and that is preservatives and other materials which are added to processed food induce low-grade mucosal damage. So the preservatives or other materials which are added to the processed food, they induce low-grade mucosal damage, and that mucosal damage predisposes to IBD. Now Crohn's disease is characterized by following. First we will briefly describe them and then we'll discuss them. Sharply delimited and transmural involvement of the gut by inflammatory process with mucosal damage. So the inflammatory process is transmural, which means that it involves all the coats of the intestine. It is sharply demarcated or delimited. It means a segment is affected by the disease, and then there is a normal segment with mucosal damage. Presence of non-caseating granulomata, we have discussed with it. Fissure and fistulas are common, and then there are systemic manifestations. Pathogenesis, numerous immune signaling and regulatory genes, along with those encoding HLA molecules and cytokines, have been associated with IBD. Pro-inflammatory, that is interferon gamma, and anti-inflammatory, immune regulatory, interleukin 10 and the interleukin 10 receptor signaling genes are involved. T helper 1 cells are involved both in Crohn's disease and ulcerative colitis. T helper 17 signaling is also important in the pathogenesis of inflammatory bowel disease. Then autophagy and cellular stress responses. Defect in autophagy and cellular stress responses contribute in the pathogenesis of IBD. Now, autophagy is a normal mechanism that clears damaged organelles and is upgraded in response to cellular stress when the nutrition or the nutrients are low, or when there is endoplasmic reticulum stress. Autophagy also means of clearing of sources of reactive oxygen species and intracellular pathogens. Now both ATG16L1 and IRGM genes are involved in autophagosome formation. The ATG16L1 mutation is linked to Crohn's disease because ATG16L1 degradation results in limiting autophagy. Okay. Then there is another factor, and that is host microbial interaction. Now there are certain proteins and their metabolites are expressed by microbes. They can either protect or promote the disease by stimulating the development of regulatory T cells by increasing mucosal barrier function, increased epithelial proliferation, and by immune regulation. Then we are again coming to the same thing, that is etiopathogenesis. The exact cause is not known. The etiopathogenesis is multifactorial. So genetic factors, 3 to 20 times higher incidence in first degree relatives. Chances are more in monozygotic twins. Chromosomes involved are 1, 3, 7, 12, and 16. Then there are microbial factors. There are certain microorganisms and viruses which are blamed, that is response against Mycobacterium paratuberculosis, measles virus, and Helicobacter hepaticus. There have been focused attention in Crohn's disease. Then immunological factors, defective immune regulation system, particularly immune suppression. So inflammation as final common pathway. Once immune suppression is defective, then there's going to be inflammation. Inflammatory bowel disease ultimately results from activation of inflammatory cells, that is CD4 T cells, macrophages, B cells, whose products can cause tissue injury. And it has been observed that immunosuppressive medication has proved beneficial and produced good results. Psychosocial factors, illness or death in the family, again stressful conditions, divorce and stressed relationships, sensitive nature of a person, and then dependency on others. They also contribute in this disease. Regarding morphology, small intestine alone is affected in 40% of cases. Colon alone in 30% of cases. Involvement is segmental. This is a very important point. The portion of the intestine is diseased, and then there is a normal portion, and then there is affected portion. Serosa is granular and dull gray, thickened and edematous. Intestinal wall is rubbery, important point, and thick due to transmural edema, inflammation, submucosal fibrosis, and hypertrophy of the muscularis propria, all of which contribute to stricture formation. So the intestinal wall is rubbery and thick due to transmural edema, inflammation, submucosal fibrosis, and hypertrophy of the muscularis propria, all of which they contribute to stricture formation. In cases with extensive transmural disease, the mesenteric adipose tissue, when the disease is extensive, the mesenteric adipose tissue extends over the serosal surface, and we call it as creeping fat. Please remember it. Important viva question. When there is extensive transmural inflammation, mesenteric adipose tissue extends over the serosal surface and call it as creeping fat. Due to fibrosis and due to hypertrophy of the muscularis propria, the lumen is narrowed. The affected segment is separated by normal intervening segment called skip lesions. Again, a very important feature. Now, one thing is important in this disease, although grossly it appears that the segments are diffusely involved in the disease, but microscopic pathology can appear patchy. So grossly it appears that the disease is involved diffusely, but microscopic pathology can appear patchy. Early stages show focal mucosal ulceration, edema, and loss of mucosal texture. Ulcers, they tend to unite, very important feature of this disease, to form serpentine ulcers, which are parallel with the long axis of the intestine, the intervening mucosa being normal and giving a cobblestone appearance. Very important point. As I told you that there are ulcer formation which are deep fissure ulcers. They unite to form serpentine ulcers which are parallel with the long axis of the intestine, and the intervening mucosa being normal, giving a cobblestone appearance. Narrow fissures between the folds of the mucosa penetrate deeply through the bowel wall, leading to formation of adhesion between the loops. So there are narrow fissures between the folds of the mucosa and they penetrate, leading to formation of adhesion between the loops. Further extension of fissures results in fistula formation. So fissures extend and result in the fistula formation and sinus tract formation, between abdominal visceral wall, urinary bladder, and genital tract. Microscopic features. First, we'll discuss mucosal inflammation. The earliest lesions which appears is focal neutrophilic infiltration in the mucosa, particularly over the lymphoid aggregates. Now, in active disease, there is dense infiltration by neutrophils that infiltrate and damage crypt epithelium. Clusters of neutrophils, when present within a crypt, are referred as crypt abscesses and are often associated with crypt destruction. Superficial ulceration in active disease. These ulcers may undermine the adjacent mucosa and penetrate deeply. There is abrupt transition between the affected segment and the adjacent normal segment. Now, I just elaborated that repeated crypt destruction and regeneration lead to distortion and disorganization of the mucosal glands. Normally, these mucosal glands are straight and parallel, but by repeated destruction and regeneration, they assume a branching pattern, and they are not now parallel to each other. Rather, they have unusual orientation to one another. Now, due to chronic mucosal damage, there is blunting of villi. Crypt destruction leads to progressive mucosal atrophy. Epithelial metaplasia is frequent. Pyloric and Paneth cell metaplasia. Now, I must point out here that epithelial metaplasia is an important consequence of chronic relapsing injury. One form, which is pseudo pyloric metaplasia, refers to the presence of gastric antral appearing glands. Paneth cell metaplasia may also occur in the left colon, where Paneth cells are normally absent. Transmural ulceration, chronic inflammatory cellular infiltrate involving all the layers with the development of lymphoid follicles in the submucosa. So, transmural inflammation, another feature. Now, I was discussing with you the metaplastic changes, which is pseudopyloric metaplasia or Paneth cell metaplasia. These architectural and metaplastic changes may even persist when the active inflammation has resolved. So, mucosal atrophy with loss of crypts may also occur after years of disease. Then another important feature, non-caseating granuloma or granulomata, non-caseating granuloma or granulomata are seen in all the layers of the intestine in about half of these cases. The enlarged lymph nodes, which are in the vicinity, they also show similar granulomata, that is, the enlarged draining lymph nodes, they show similar granulomata. Clinical features: initially mild diarrhea, fever, and abdominal pain, spaced by asymptomatic periods. Anemia after long period of time due to bleeding, and pain in right iliac fossa appears as in acute appendicitis. Bouts of diarrhea may lead to fluid and electrolyte loss. Then there is weight loss and weakness. Fibrous strictures and fistula formation takes place between the loops of intestine, urinary bladder, genital tract, and perianal fistula may result with abscess formation. Extensive small intestinal involvement leads to protein loss, malabsorption, and vitamin deficiency. Now, there are number of factors which are responsible for the reactivation of the disease, and that can be associated with variety of external factors, including physical or emotional stress, intake of specific diet, and cigarette smoking. Smoking is a strong risk factor for the development of Crohn's disease, and in a few cases, disease onset is associated with smoking. It is very unfortunate that even if a person stops smoking, the disease does not go into remission. Extraintestinal complications: migratory polyarthritis, spondylitis, erythema nodosum, clubbing of nails, cutaneous nodules formed by granulomas, uveitis, sacroiliitis, pericholangitis, and primary sclerosing cholangitis, renal lesions, amyloidosis. Now, another important point: risk of colonic adenocarcinoma is increased in patients with long-standing colonic disease. When the disease is long-standing, that is, the Crohn's disease is long-standing in the colon, risk of colonic adenocarcinoma is increased. Now, this photograph shows gross features of Crohn's disease. The middle portion has got a thick wall, and the mucosal folds are lost, as seen in the circle. Serosal surface shows reddish indurated adipose tissue that creeps over the surface called creeping fat. Serosal inflammation leads to adhesions. The area of inflammation tend to be discontinuous throughout the bowel. You can appreciate this. This is the normal area, this is the normal area, and in between it, this is the structure segment. The mucosa in Crohn's disease show a cobblestone pattern due to combination of submucosal edema and interconnecting deep fissured ulcers. These are the interconnecting deep fissured ulcers. We are just coming to that. Cobblestone pattern with deep fissured ulcers. Here it is mentioned. This is the cobblestone pattern showing deep fissured ulcers. These are the deep fissured ulcers, and now you can appreciate cobblestone pattern with mucosal edema here, and in the upper photograph these are the interconnecting deep fissured ulcers, whereas lower down cobblestone appearance due to mucosal edema. In Crohn's disease, thickening of the wall and stenosis is shown. Now this photograph shows normal bowel wall, red, whereas lower down bowel wall is thickened and the lumen is reduced or stenosed. Histological feature, as I told you, there are non-caseating granulomata. They are non-caseating granulomata here. And you can see that there are even giant cells which are present in the granulomata. Maybe Langerhans type of giant cell, and in the surrounding, this is the surrounding showing lymphocytic infiltration. Now you can appreciate here Langerhans type of giant cell. In Crohn's disease, there are epithelioid granulomata, dense inflammation in the surrounding areas, and you won't find mycobacterium by tissue ZN staining. So by this you can rule out tuberculosis. No other complication, one complication which I have already told you is fistula formation. So fistulae formation can take place between the loops of intestine, bladder and skin. With the involvement of colon, perirectal fistulae are common. Now we are going to discuss tumors of small intestine. Tumors of small intestine, they are rare tumors. Stromal tumors mostly seen are leiomyoma or lipoma, which develop in the wall of the intestine. Now, adenoma and adenocarcinoma of small intestine, again, I must mention here, they are rare tumors. They can be sporadic and proximal in older patients. In younger patients, they can be associated with underlying conditions such as the FAP syndromes and Lynch syndrome. So two syndromes, they are associated, that is FAP syndromes and Lynch syndrome, with adenoma and adenocarcinoma of the small intestine. Adenocarcinoma of the distal bowel may be a complication of Crohn's disease. More common malignancies which are seen in small intestine are metastasis, lymphoma, and carcinoid tumor. Adenoma. Small intestinal adenomas are extremely rare. Often admixed with adenocarcinoma. May arise around the duodenal papilla and present with biliary colic, cholangitis, jaundice, and pancreatitis. Patients with FAP, that is familial adenomatous polyposis syndromes, have about 300 times greater risk for developing carcinoma of the small intestine than non-polyposis patients. An important point. So these two, the syndrome is, one is FAP syndrome, another is the Lynch syndrome. But those with FAP syndromes, they have got 300 times greater risk for the development of carcinoma than non-polyposis patients. Now I'll discuss briefly adenoma of small intestine. Gross pathology, multilobulated and soft, may be pedunculated or sessile. Tubular adenomas, they are usually less than 3 cm in size, whereas villous adenomas are more common. Villous adenomas are more common and larger than 5 cm in size. Adenomas in patients with FAP associated syndromes are mostly multiple. Microscopic features. Tubular adenoma. Well, adenomas can be tubular adenoma or villous adenoma. So tubular adenoma, tube-like glands lined by epithelial cells containing hyperchromatic nuclei. Mitotic figures present at crypt levels. Few goblet cells, they can also be seen. About 20% of tubular adenomas contain carcinoma. Then villous adenoma, there are papillary fronts or leaf-like configurations containing central lamina propria cores lined by dysplastic epithelium. So there are papillary fronts having central core of lamina propria, and they are lined by dysplastic epithelium. Nearly 30 to 60% of villous lesions contain invasive carcinoma. Now we come to malignant tumor, which is adenocarcinoma of small intestine. The lesions are polypoidal in 25% of cases. They are ulcerated in 75% of cases. Size vary between 2 to 15 centimeters. Strictures develop and they produce intestinal obstruction. Microscopic features of adenocarcinoma of small intestine. Malignant features include mucinous differentiation. There are cribriform glands. These glands may be fused together. Marked stratification of the nuclei, cytological anaplasia, and desmoplasia is an important feature. Atypical glands present adjacent to the blood vessels, fat, ganglion cells, and often show submucosal invasion. And there are uncommon histological features which include papillary adenosquamous carcinoma, signet ring cell carcinoma, and small cell carcinoma. Now this is a photograph showing the microscopic features. This is the adenocarcinoma which arose in the ampoule of water. Primary small intestinal carcinomas are rare, but majority of them arise in the region of the ampulla, where they become symptomatic through biliary or pancreatic obstruction. You can see this adenocarcinoma, variable size glands lined by pleomorphic cells. Then there is another photograph showing the gross feature, showing that in small bowel, metastatic tumors are common and they cause mass-like structures, causing local obstruction, and the primary sites are from nearby colon, ovary, pancreas, or stomach. They are the common sites where small intestine can get metastatic tumors. Now, this is the tumor, which is a benign tumor, which is a lipoma. It's a small, discrete, yellow subserosal mass, which is lipoma of the small intestine and found incidentally, showing that connective tissue tumors or mesenchymal tumors are more common. This is the photograph showing histological features of the lipoma, which is composed of mature adipose tissue. Now, this is another mesenchymal tumor, which is leiomyosarcoma of the small intestine. It is large and has got bad prognosis. Sarcomas are uncommon at this site and should be differentiated from other neoplasm. This is to show you that mesenchymal tumors, one example was lipoma, which was a benign tumor, and this is the malignant tumor, which is leiomyosarcoma. Now, malignant lymphoma derived from mucosa associated lymphoid tissue of the small intestine, usually B cell. Celiac disease is a predisposing factor. Tumor may be multifocal and spread to the local lymph nodes. Now, this is the gross appearance of the lymphoma of the small intestine, which is a non-Hodgkin lymphoma. You can well appreciate this. So multifocal, irregular, tan to brown masses, and this is the lymphoma which is seen in the patient of AIDS. This is the microscopic feature of non-Hodgkin lymphoma of the small intestine. They are large blue cells which are infiltrating through the mucosa. They are infiltrating through the mucosa. Now, this is the higher magnification of non-Hodgkin lymphoma which is present in the small intestine, and you can well appreciate that the cells have prominent nucleoli. There are mitotic figures which are occasional, and this is again the mitotic figure, and the chromatin is clumped. Now, gentlemen, I have discussed the subject. If you have any question, please write down in the comment box, and inshallah I'll answer it.